So first I wanted to say welcome everyone. I thought we'd start with just a little bit of a meditation and just a breathing practice, since I think we're all pretty ramped up, and I thought we could all maybe benefit from just a little bit of settling. So if that works for you, go ahead and just make yourself comfortable wherever you're at, and ideally sort of just notice the cushions of your buns on what you're sitting, and allow what you're sitting to to really support you, so you can relax into wherever you're sitting. And if your legs are crossed, you can uncross your legs. If your arms are sort of crossed, go ahead and uncross your arms. And I would invite you to just allow your hands to sit comfortably in your lap, on your legs, or on your belly, whatever feels comfortable. And then I'd like you just to notice your breath, and notice if your breath's shallow or not, and don't change it, just notice your breath. And then I'd invite you to then just track your breathing. And as you breathe in, I'd like you just to start to count. You can sort of notice your breath and just count as you come in. So it'd be like 1, 2, 3. And then as you exhale, 1, 2, 3, 4. Make your exhalation a little bit longer than your inhalation, but make sure it's just nice and comfortable. And then when you're ready, I'd like you to invite you to put one hand on your belly and just notice your breathing through your hand. And if you notice that your hand isn't moving much, try and allow your diaphragm to relax and your belly to relax as you breathe, to let the belly come in and out as you're breathing. Then I invite you to take your other hand and just put it on your chest and gently lay it over your heart area, the metaphorical sort of energetic heart that sits sort of over the breastplates, between the breasts, just above the sternum here. And just notice that go in and out as you breathe. You can leave your eyes open or closed, whatever feels more comfortable. And when thoughts arrive and arise through your mind, which they will always do, just let them go through. And just when you notice them, just allow that to be a calling to say, oh, I'm thinking, and just come back to your breath. It's normal to have thoughts, so just don't beat yourself up over them, and just say, oh, that's helping you remember that you're thinking, and now just come back to your breath. The beautiful thing about that is over time, you'll learn to separate your thoughts, your thinking mind, from your true essence. And you'll be able to then create a little space between what your mind's thinking and where you sit in your core being. And now I'd like you to just take a moment and be thankful. Just allow some gratitude to come in, just to appreciate where you are right now and how fortunate we are right now, all of us here collectively and individually. Just to allow that to sort of fill your essence. Just drink it like golden water. Just allow it to come in and saturate your being. How beautiful it is where we are. how beautiful it is that we have our health for the most part, for most of us and all of us. And then to shift a little bit towards thinking about those that love you. So if someone comes to mind, just allow that to rise up into your thoughts, who that might be, and allow that love to shower you a little bit. Allow that person's love to soak in. Allow yourself to take that in, to give yourself permission. And if your mind wanders, just come back to your breath. And if you feel comfortable, you don't have to do this last part. If you feel comfortable, take some of that energy and that love and really try and think about those out there in the world right now that are suffering, that are challenged, and send them some good juju, some good love. To support them in their efforts for recovery or to help those that are suffering. And now allow yourself just to come back to your breath again. Come back to yourself. Notice your breath. Notice your body, how it feels, where the tension might be in your neck or in your jaw or in your chest, low back. And you can give that a little bit of attention and all this love and caring that you've generated and direct it into those spots. And then when you're ready, go ahead and you can wiggle your fingers a little bit and your toes and open your eyes if they're closed. And just allow yourself to come back into your room. I would say the room, but we are all individually in our own rooms. And bring yourself back here. So I'm going to do a little bit of, we're going to run through a little bit of data. So we'll move back into our brains a little bit. But I wanted to anchor us a little bit to give us a little bit of grounding to allow us to sort of feel, to move to learn from a centered, comfortable, grounded place. There's a lot of fear and within each of us, me included, as well as collectively. And I think it's important for us to sort of ground so we can have a really thoughtful, productive, and generous conversation. So, all right, so let me go ahead and share the screen here. All right, so let's see how I can, there we go. Okay, so so last time I gave a talk, it was about 2 weeks ago, in 2 days, and this is sort of what the picture looked like. And we had here 752 cases in the U.S. with 4,000 deaths. New York wasn't even on the list there. You can see on the right there under deaths. So 2 weeks later, things look a little different. We went from 130 cases to 430 some odd cases. We went from 700 cases to now we have 55,000 cases in 2 weeks. And you can see New York has got 200 deaths, and today alone in one hospital, there were 18 deaths in Elmhurst in Queens. So New York is really getting hit. Um, so I want to sort of frame it a little bit and give you a perspective from the healthcare professional perspective. This is sort of the backside of the office, if you will, of what's going on. And I'm in touch with a lot of people throughout the country. So I just wanted to give you a little bit of a flavor. So the equipment you see them wearing is in really short supply, that face shield, that mask, and those gowns. And those gloves less so, but they may become more and more so. And this was from a couple days ago, and I just read today, it's even worse in the same hospital today. And you can see here, this is a ER doc in the ER saying, we're running out of personal protective equipment. That's the face mask and all that, the PPE. We're being asked to reuse our masks. We admitted over 50 people in one shift, which is unheard of. The nurses upstairs won't take any more patients. We have to push our patients ourselves upstairs. They're no longer testing patients unless they're being admitted because they're running out of tests. The ICUs are full. So New York right now is really imploding. In particular, this for some reason, this hospital in Queens is particularly having a difficult time. Apparently, they're now going to make that hospital anything other than coronavirus is not being redirected outside of that hospital elsewhere, and they're going to convert an entire wing to ICU beds, and they're trying to get more ventilators. So New York is really getting hit hard. And then this was just, if you're interested in, I could share it with you. This is the chair for surgery at Columbia Presbyterian. This has been a very active day during which the hard data has become alarming. I wish I could use a more comforting word. Today, the New York Presbyterian had about 300 patients, 200 awaiting testing, 50% increase in one day. And we don't have to go through all this, but they're really concerned. And as you can see here in the second paragraph, they talk about using 40,000 masks per day. And downstate region uses 3 million masks per week. The entire strategic reserve only holds 75 million masks. They just got 150,000 masks, but that gives them 2 days worth of masks. So things have changed since supposedly there's going to be 1 million masks. I think it arrived in New York. But again, clearly this is an issue. Apparently, since there's so many new companies that have formed to make in China to make masks that are, some of them are not so legit, and most of them apparently are sort of borderline, and it's hard to get really good masks, then the raw materials are now becoming in short supply. So this is sort of capitalism at its sort of, worst, best, ugliest. The last paragraph really sort of got me. Nothing would give me greater pleasure than to apologize profusely in a few weeks for having overestimated the threat. That would mean we never exceeded capacity. The next month or two is a horror if we're not underestimating the threat. So what do we do? Load the sled, check the traces, feed Balto, and mush on. Our cargo must reach known. Remember that our families, friends, and neighbors are scared. Anyone working in healthcare still enjoys the rapture of action. It's a privilege we must mush on. So this really touches my heart. So I just wanted to sort of share that with you in light of, fortunately, London Breed and others in California have really locked down earlier than New York did. New York, of course, is high density. People are traveling in subways. People are in small elevators. There's lots, just try to go to a grocery store in Manhattan, and those aisles are so narrow. So, thankfully in this region, we don't have that sort of intensity and density, and we acted earlier. So, but right now that is clearly a hot spot. So what's interesting, I'm going to share with you some data that came out of China. A gentleman presented at Harvard, MIT, Harvard professor, and did some work out of China. And I found this really helpful. So what he said is, how these guys were suiting up with all the protective gear. They had 42,000 medical workers. Not supposedly, none of them were infected. I don't know how true that is, but clearly they didn't have a big issue. We are having a big issue. Italy's clearly having a big issue as well. So this is an example of from March 10th. This is what these guys are wearing compared to what they were wearing in China, right? Big difference. They had 95 masks there, which is good, but you could see that there's a big difference. So this is I'll go through a few slides that I plucked out of this presentation, and if people are interested, I'm happy to add these as attachments, some of this material I'm going to go through if you want to read more about them. But he gave this presentation, and I thought it was quite interesting to see how they managed it in Wuhan. And he's like, look, I want to start with a positive message. Look, we can learn a lot from the Wuhan experience, so let's do that. And this is a beautiful picture of Wuhan. There's 11 million people that live in that area. What they were concerned about is, you can see the trajectory here. It was arcing pretty steep there. That R means how infectious things are. So if I'm infected and the R is 3, that means I'll on average infect 3 people. And for some of you that chimed into the last talk, you know about that figure. And measles was 15, or is 15. SARS, I mean, the early SARS, and the other one, the Mediterranean virus, were both, under 1, and so they didn't propagate. This one's is around 2 to 3, depending on what's going on. So you can see that early arc is around 3.5. The middle arc, where it says 1.25, is where it is when they went under lockdown with traffic bans and many quarantined at home. That's sort of what we're doing. But then they did other things which took it down. You can see how the graph goes down. You can see, project out that blue, if you don't do anything else, he's saying this is what it looks like. If you just do what we're currently doing here, basically, that's what it looks like, which is way better, but it doesn't end the epidemic. And so what I'll show you in these next few slides, how they got it to what they say is 0.3, is they did centralized quarantine. So if you have an infected person, let's say it's me, and grandma's living with me, my mom, I'm going to infect my mom, and likewise. So by cohabitating people across the generations, we have a problem. So that's part of the issue. The other part, so this sort of the flow here was suspected cases were priority 1. Community leaders checked every household door by door for subjects. I mean, right? So it's a different world there. They clearly can do things in a different way than we have. They mobilized 42,000 healthcare workers to go through neighborhood, and then close contacts with cases but without symptoms. So they took everyone, they did this is sort of contact tracing, magnified, and tested them. So we're clearly falling way short here on doing that. I just received a reply from the Department of Public Health today from the director, because I'm trying to coordinate stuff with them, and they themselves are clearly stuck in the bureaucracy as well, because we offered an idea for them, and they're sort of creating bureaucratic hurdles. What they did here is they took these 4 groups. So if you test positive, you move to these mobile cabin hospitals, which is basically they took a stadium and converted it. And I'll show you the picture. Group 2 is suspected, right? They centrally quarantined those people in hotels. And then if you had a fever, they centrally quarantined them in hotels. They don't put them back in their house, which is what we're doing right now. Close contacts with confirmed suspects, again, they were quarantined in a different location because they were sort of a step down from everyone else, groups. So, and then if they, of course, got sick, they move over to the hospital. And then if they got this, well, not hospital, these sort of mobile units that were sort of very mellow places to hang out. I'll show you a picture. Of course, if they got much more sicker, then they moved to the hospital. So that way you don't overburden the hospital system. And this is an example of a converted stadium. So you can see here for the mild to moderately sick, this is where they were. We have a lot of empty stadiums right about now all across America. Okay, so take home message really, this is 50 slides later, is, large scale screening using symptoms with and without testing kits. They just sort of said, okay, there's the standard public health contact tracing, that all good. societies do. Unfortunately, in America, it's been atrophied, our public health system. They increased the testing capacity dramatically. And then they did social distancing, home quarantine, which is what we did. And then the last bullet point that I just walked through. And then, so protecting the 4 vulnerable groups, healthcare workers are at a much higher risk of being infected, especially if you don't have the right protection. Elderly people, family members, and close contacts are confirmed as suspected cases. And then children's infection risk is much lower than adults, but the risk increases with time periods. So over time, if they have repeated exposure, I think is what he meant by that. So the thought here is, centralized quarantine of ill patients and exposed early can really reduce the number of new infections. And by moving into a stadium, then you completely change the hospital overload burden, and they can convert the entire hospital to handling just much, severe to critically ill patients. So there's a couple of great articles that have been put out. My colleague and friend David Katz, who's at Yale, wrote a great piece that I think is worth reading. It's just a couple of days ago. Tom Friedman then sort of, I guess 2 days later, had an interview with, interviewed him and talked to a few other people, and sort of then elaborated more on what David was saying. And I don't know if I included the slide in here or not, but I'll look and see if I did. But he has on his website, there's a slide that sort of breaks it out. And what he basically says, which I agree with, is let's get people back to school and work and take the vulnerable populations and put them out of circulation, put them in lockdown and isolate them in the ways that we can, sort of like ideally, he didn't talk about the Chinese method, but whatever we think's the right way. And let the kids get exposed, let them get sick, they'll become immune, let the healthy people at work that are healthy go get exposed, they'll get sick and they'll become immune. There will be some deaths, but the rates are clearly a lot lower. And then you'll have what's called herd immunity. So once the community at large has antibodies, they're immune to this, they're no longer infectious. So they can become exposed to it, they don't pass it on. So and now you can then slowly release the vulnerable populations back into society. What we're doing now is locking it down. And then when do we go back into circulation together as a group? We're still all naive to this virus. So that's sort of the question. Another follow-up article, he talked to this philosopher, and it's really worth talking about what is finding the common good in a pandemic, and how we're sort of all being isolated now from each other in an interesting way, and how is that yet for the common good, and what does that mean? It's an interesting article. In one piece he speaks to here, the Friedman says, I have been writing about or following or actually proposing a phased strategy, following meaning David Katz and a few other people, practice social distancing and sheltering. So, do that for a few weeks. Whoever is going to manifest it. Those who can recover at home would do so sequestered. And then number 2, alongside this, we would do much more testing, actually get a grasp, which we are, as many of you know who I did testing on, this is ridiculous, the problem, and I'll talk about that later for those that don't know. And then, the young people and how many in their 40s, you can actually do a seroprevalence study, see, and you can track it over time and repeat testing in a given community and see when we get herd immunity, which would then tell us, okay, there's enough people that are immune, let's start letting people back into circulation. So that's the summary. There's a great article by a guy named Neil Ferguson, who and group at the Imperial College and their COVID response team. And they did a lot of different modeling here, and they're talking about what's the impact of non-pharmaceutical interventions. And you could see here, so the red line this is the UK. The red, I believe I took this one from the UK, but they're roughly the same. We have a little bit more actually bed capacity per capita than the UK, but anyway, so the red line, clearly it doesn't really matter when you look at the surges. So the black line says you do nothing, and this is what it looks like. This is how many people are going to go that need critical care beds. So it's completely overruns the system. And then what are the different other options? And the take-home message here really is, if you do what we're doing now, which is the green one, eventually people go back into circulation. And then in the fall, which is what happened in the Spanish flu, right? In the fall, then you get a big hit because everyone's back into circulation. And all of a sudden we have a repeat of what's just happened. If you do the orange line, which is case isolation, household quarantine, and general social distancing, the method we were talking about, you get a little bit more in circulation. That's why the orange line, you could see it's creeping up to the surge capacity. But then, and if you do it right, then you could see the surge capacity in the fall is much less. Still overwhelming the system in his model, but definitely way better. And so that it's worth a read. And I had to read this a couple times, and I'm still digesting some of the data and looking at some of the references to see where he pulled this from. So we talked about this now. So if you look at the US, we moved from 752 cases. Now we have 55,000. And you can see New York makes up half. California taking up, what, only 5% right now. This is a bit dated, but this is MMWR that was put out on the 18th, and it only took 4,000 cases at the time. But you can see the case distribution of those that were hospitalized. And what the take-home message here is, as you get older, you're at increased risk. And it really starts to step up above age 65. But it steps up all along the way, you can see. And that's really the main take home in my mind. And so you could see up in the right-hand corner there, half of the ICU admissions are folks over that age group, 80% of the deaths. So, and then this is a little bit of a different view, talking about hospitalized patients in the US currently. So what this is saying, there's a lot of folks that are younger. So that, 20% is actually in the age group 20 to 44. And so it's behaving a bit differently than it did in China. But we have to see as more data comes out. I think there's a lot of flux potentially right now in the data. It's still early. So I just want to talk about a couple of different scenarios, and then we can open up some more questions after I walk through a few more things. So what's considered high risk? If you're immunocompromised for one reason or another, if you're age, if you're pregnant, we don't know. There's a study going on right now at UCSF, and I think it's a national study looking at women that are pregnant. And then chronic disease, particularly diabetes has been called out. There's some other ones that are called out. It's a little unclear what that really means, because does that mean just hypertension? Does it mean you had a big heart attack? And then is it only among people that were in the ICU? And that's why, because they had a heart attack, they had bad coronaries to start with, and now they get quite ill in the ICU. And that's why they're dying, not just because, if I have hypertension, that means I'll get a worse pneumonia, which doesn't make sense. So there's a lot that still needs to be worked out about that. But in general, if your immune system is compromised in a real way, or if you clearly have pulmonary issues, because this is a respiratory virus, that clearly puts you at increased risk. And then, of course, people like me, healthcare workers, just because we're around it so much, particularly if we don't have appropriate personal protective equipment. And we're at high risk for transmitting it. So we can then give it to our family, we can give it to other patients as we go from one patient to the next if we don't do proper hygiene and proper care. So here's a couple of scenarios. So what if I was exposed and I don't have any symptoms? So here's an example, 55-year-old guy and his son spent a weekend with friends. 2 days later, they developed symptoms, and his friends were found to have COVID-19. So first of all, please call me. I want to know, I want to be involved, or call us as the team. And you should, if you know someone that is a source that is positive and you spent significant time with them or spent any time with them, and then I'll qualify that in a moment, you should self-quarantine and isolate yourself away from people that are high risk, of course. And then we want to arrange to get you tested. And there's different ways to get you tested, and we can talk about that. The part that what does it mean to be exposed? The data is a bit unclear. I've seen some data say that you need repeated exposure. I've seen other data say, it can be easily transmitted because it lives on cardboard boxes and tables. The original study I saw said 9 days. More recent studies are saying 3 to 4 days. Cardboard, 24 hours. It's hard to know, but clearly on inanimate objects, doorknobs and things like that. So you can get it, and the thought is you can be transmitted that way. So, better safe than sorry. So at this point, so that's my recommendation. Okay. Another case, you're symptomatic with or without a known exposure. So a couple of different examples. 50-something-year-old woman goes skiing with a whole bunch of friends. 8 of 10 of those friends become ill. We know a couple of them are positive. One's in the hospital. You develop as this person symptoms. So what do you do? So clearly you need to be tested. Clearly you need to really be isolated. And I'm inclined to treat. And we'll talk about what that means a little bit later and how good the data is on this medicine, which it isn't very good, but we have no other clear medicines. So I think there's little downside, and therefore you were hanging out with a group of folks, 8 to 10 people are sick, people are getting tested, there's a high chance you have coronavirus. So another example, gentlemen, these are both real cases actually in our practice. Someone else goes, the age is a little off and stuff, but just for sake of explanation. So person goes traveling to Switzerland, they're surrounded by folks that are from other parts of the world, people are sick there, he gets sick. So again, we did the same protocol. And again, I would actually, in this case, we don't know if someone necessarily it is positive there. So then it's a conversation. Do you want to start this medication? We don't know if anyone there actually had the virus. So now it's a risk-benefit conversation. We don't even know if this medicine really works. There are side effects to it, although it's relatively well tolerated. And so as long as the person's doing well, relatively speaking, and not developing a pneumonia, my bias would be to wait. But that's an individual conversation. The question then is how long to self-quarantine, and I'll show you some data on that. And it's changing. And it's looking like longer is better if you're actually infected. If you're not infected, then the thought is 2 weeks currently. So here's some of that data. So this is a recent publication, and there's so much coming out now. It's just amazing how much work is being done on this. And literally every day there's 5 or 6 studies coming out or more that are coming. So in this case, they took 23 people. So it's not a huge study, but 23 folks, and they sampled them serially over time. And you could see the days, which is what D means, 0 through 29. And they took folks that were really sick. The folks, the endotracheal aspirate means that they were intubated, so they're critically ill. And that's 3 data points. And then the rest of the folks, the saliva. And you can see they were able to, this is with PCR testing. So and I'll show you how you do it, but you put the swab in some of you, I've done it to some of you, you put the swab down through the nose, into the back of the throat, and sample the material back there, put it in a little jar, and then I'll send it off to the lab, and it checks by PCR for the viral antigen, the actual virus itself, not the antibody, but the actual virus. And you can see it's detectable all the way out 20 plus days. So a third of the people were still positive, detectable past 20 days. So then the question is, does that mean you're infectious? Because we also know, and I don't know if I have a slide in this or not, but we also know that antibodies start to show up by somewhere between day 5 and 10. So if you have antibodies, maybe this virus is coated with these antibodies, and therefore you're not as contagious. We don't know the answer to that. All we know is this side of the conversation, which is we find virus, but we haven't really been able to nail down the infectious part yet, how contagious you are. The thing this also tells you is that early on, look how high the viral titer is. So they come in with symptoms day 0, and boom, look how high the viral load is. So it's up near 5 and 6 where that line is, meaning that they had virus before they came in with symptoms. So people are presenting with a lot of virus in their body before they actually have symptoms, which is why we think it's so much more contagious, because people are in circulation not knowing they're ill. The common presentations, and this is pulled from a whole bunch of data you can see at the bottom. So a lot of people have a fever. Not everyone though. And you could see only half of them on admission. So people were sick without a fever. Cough, for the most part, could be dry or productive, shortness of breath, and some body aches and others, that's myalgias. And then the fever, cough, and shortness of breath that we say. Initially, if you remember, you had to have a fever, cough, and shortness of breath, and know someone that came from China in order to be tested. Well, that would be only 15% of the people, even if you remove the contact of China. So you could see things are being engineered right now, not for the safety of the population so much, but rather for the issue of demand and supply of tests. Now it's changing dramatically now that tests are becoming more available, which I'll talk about in a little bit. So less common symptoms as well, you can see. Nausea, vomiting is NV, URI symptoms like headache, rhinorrhea, so runny nose, sore throat, diarrhea. It occurs actually, but less frequent. So this is how we do the testing. I hate to say it, but for all my small sampling, women and younger adults do just fine, but it's us men that have a hard time with it. So not everyone, not all men, but in general. And that's how we do it. We swap, we sit back there, we twirl it a little bit back and forth and pull it back out. So the site, so I used Quest, and I'll just tell you a little bit, and some of you who I tested will know this firsthand. So I tested, this is now 2 weeks ago. Or is it 3 weeks ago? 3 weeks ago, I think it might have been now. Again, 2 weeks ago. So 2 weeks ago, Thursday, I tested 2 people, had the results back on Monday, the following Monday. I tested myself because I was a bit ill, and someone else on Friday had those results on Wednesday, I believe. And I was negative, by the way. And then tested a whole bunch of people the following Monday, and we only got the results today, 10 days later, or what is that? Basically, and essentially 10 days later. So even though they said when we sent it, it would be 3 or 4 days, and then we called it, it'd be 6 days, and then actually turned out to be 10 days. If you go to UCSF, they've expanded their labs. Initially, it was 40 a day they could process, and 300, and they can now do 1,000 a day. Stanford as well has expanded dramatically. The Marin department, if you're a resident in Marin as well, I can help facilitate on the back end, getting the calls. So their turnaround times are super quick. And so at this point, given that Quest is so log jammed up, my recommendation is to go through them. I'm going to try and contact them and see if they'd be willing to accept specimens from me. I'm not sure if they will be willing to, UCSF in particular, but that's my next step. But short of that, I can call the VIP, the back lines into UCSF and Stanford, and then get you short tracked through to be tested in their testing facilities. So this is some data just looking at testing. This is for California. So you can see here in the United States. So the United States here, 367,000 tests will be done. Only 53,000 have been positive. Now the ratios here again are higher than normal, right? Because we're taking a subgroup that's clearly a biased subgroup, right? They're symptomatic, they're much higher proportion. And then you can see here in California, you can see 27,000 people have been tested, 10% are positive, with 12,000 pending. So you can see there really is a huge backlog. So treatments, so right now there's none that are FDA approved. You have President Trump touting all sorts of baloney, unfortunately. And the ones that are interesting to me are the hydroxychloroquine and azithromycin, and I'll show you why in a moment. And there's an HIV drug made by, or an antiviral drug made by Gilead that they tried using for Ebola that wasn't super great, but they think they're looking at it now for this particular virus. And there's a list of other ones that they're looking at, and they treated a lot of people in China with, but the data isn't, there is not good data yet that I've seen on any of these drugs. So let's just spend a moment talking about Plaquenil, is known, or hydroxychloroquine. This medicine's used for lots of people right now. It's not, I mean, it was historically an anti-malaria drug, but not really used for that much anymore because there's huge resistance to it. So instead it's used for people with autoimmune conditions. It's really well tolerated given the choice of medications that they have to choose from, particularly people with rheumatoid arthritis and people with lupus. And now those people are having a hard time getting their medication because, thanks to President Trump, everyone went out and tried to get this medication and have it on hand. And so now these people suffering with these chronic conditions are having a hard time getting the medication. So what I've done, just so you know, is I've ordered a supply of medicine, and we have a small supply now, and we'll have more supply coming in. And so that gives me the ability to then, if someone is sick, dispense it to them and not, give it to everybody so that it's never used. And then these people with chronic conditions don't have the medicine, have to switch to a more potentially lethal or just more toxic medication because this is not in supply. There are a lot of generic companies right now that are ramping up manufacturing, so hopefully the gap will be filled quickly. This study shows it was small. It was 30 people in the study, and I'll just talk about. Let me tell you about the study for a moment. I'll go back to the graph. So 30 people in it. 6 people they didn't have follow-up on. That's a huge number. It's small. They didn't randomize people, but they did have sort of 3 groups. And I'll go back to this in a moment. So what this shows us here is the black slide, or the black line is controls. They didn't get anything. I think there was 6 people. And then the blue line shows they just got the Plaquenil. And then they added azithromycin, not because of bacteria, but they think it might have an antiviral effect for this particular virus, or there may be some other means. It's not really clear, but that was the hypothesis. And so you can see here by day 5 eradication of the virus. So on the left there, that vertical axis is talking about PCR positive samples. So what I was talking about before, where we put the swab in the back of your throat through your nose, that's PCR testing for the virus itself. So there's eradication, which was amazing and better with the combo than the Plaquenil alone versus the people that got nothing. So pretty impressive graph. It is only 6 people in the black group, and they lost 6 people, both of which were in the treatment groups, by the way. So they had, so that's just, this is the data. This is what we have for right now. These drugs are helping so this is this is a doc. He's an infectious disease doc. I think it was for Kansas Medical Center, University of Kansas Medical Center. His thoughts are, look, if someone's in the hospital, we have nothing else to give people, let's use it. It's relatively safe for people, and it can cause QT prolongation. So it can cause, for people that have conduction issues with their heart, both these medications can prolong that conduction issue. So for that reason, it's worth saying, okay, if I have that issue, then I need to think twice about it. And it's theoretical. It's not a huge definitive contraindication, but it's known that we should just be mindful of that and monitor people if they have that situation. But otherwise, his attitude, these 2 gentlemen's attitude is, let's give it to people that are in the hospital and that are sick. And we talked about sort of supply chain issues, and that UCSF and other people as well are studying this as we speak. It does cause nausea for a lot of people in GI distress. And that's why we divide the dose, 1 pill 3 times a day rather than taking it all at once. Chronic use has been associated with retinal problems, but for people with lupus and rheumatoid that use it daily. Okay, so I wanted to sort of pause the slides. I'll stop sharing, and then just open it up to questions that people may have. Topics, things that I asked, things I covered, or things I didn't cover, because there's a lot to cover. So you can either say it verbally or send it through chat or whatever works.
Brad?
Yeah.
This is Bernadita.
Hi.
I have a question. Regarding treatment with the combo.
Yeah.
The data of those patients look very good, but on the other hand, it's kind of scary when you say, the two drugs have the QT, the potential of QT elongation. Okay. So you have no idea, you don't have any precedent of cardiac problems, but you don't know either that may happen. Would it make sense to just start with hydrochloroquine and then see how that goes? Or I mean, I don't
Right.
know.
So I'll say, so I would say a couple things. So one is, I can get more feedback from some people that are pharmacologists and understand the kinetics better. I've never been worried about it for azithromycin with patients. It's really mild.
Okay.
With Plaquenil, it's given all the time. And rarely have I ever heard anyone concerned about it. Right, it's out in the community. It's millions of people who take this medicine. The combination, it's rare that people do the combination,
Yeah, that's why I'm thinking.
Right.
Because
So
I know that the two separately are one thing, but the combination is the issue.
So it'd be worth, if we could find, someone will do the research because the data is there, I'm sure, find people, it's easy to do. And hopefully I can ask the people at DOR, Division of Research at Kaiser, to take your database, find people on Plaquenil that were hospitalized and given a Z-Pak, how they do, right? Probably in Northern California, Kaiser, there's 3 million patients. I guarantee there's at least 100,000 of those people. So the data's there, we just need to find it. So it's a good question. I can do a little more research on that.
I think that would be great.
Yeah.
Brad, it's Howard. How you doing?
Hey, Howard.
So I think if I may generalize, take some liberties and generalize, I think a lot of us want to try to do some things to help, but we're in the vulnerable population, in quotes. One of the things that's out there is to give blood. Can you comment on the prudence of that, one, and two, if you do condone it, where in Marin we could go to do it?
I know UCSF, bone marrow transplant in particular, definitely needs blood. In Marin, I'd have to look. So let me ask. But I know UCSF needs it. I do think, I think it's a good idea. I know they're taking proper precautions at UCSF. So if you're open to that, I would do that, but it's, it's from point A to point B and back. They're definitely taking precautions on the receiving end, receiving you, for sure. So I don't think you need to worry about that at UCSF. I would need to see what's going on in Marin and who's doing it to make sure that I could give it the same blessing. So I can get back to you on that.
Okay, yeah, thank you. And just the logistical details of which UCSF campus and so forth when you do. Thank you.
Yeah, thanks for asking.
Brad?
Yes.
This is Rina.
Hey, Rina.
Hi. Well, we are talking all the time about the benefits of testing at large and protective gear for the health providers and the importance and how that but we're sitting here. What is happening in the state or in the Bay Area in terms of making that more available? Both the protective gear, say for health providers, as well as testing for the population.
So for health providers, UCSF just received, looks like 500,000 masks, what they're really called respirators, these N95 respirators. So 500,000, so that's good for UCSF. Kaiser is supposed to be receiving 1 million respirators for Northern California, Kaiser. I don't know if it's received yet, but when I spoke to the head of procurement at Kaiser, that's what she told me. I've been pretty involved in this, as you know, Rina, for those that don't, because I've been trying to orchestrate getting these respirators to the hospitals. And it's pretty complicated to get the high quality ones. China has been not letting it, the highest grade respirators leave China, even though, for example, 3M is a U.S. American company. For some reason, the president hasn't negotiated with the CEO of 3M to, say that, allocate X number of 3M FDA approved respirators for the United States. So but the good news is Kaiser and UCSF look like they're receiving it. I just got off the phone today with San Francisco VA because I'm going to be giving some respirators to them. They've been waiting, and 2 days ago they received 2,495 masks. That's all. Federal government, this is UCSF affiliated San Francisco VA. So thankfully UCSF residents will have their N95 masks. They'll probably have to reuse them when they go over to the VA. I'm not sure how they're going to coordinate that across hospitals, to be honest. But so the VA is clearly having an issue, and Marin General have yet to reach out to. So that things are getting better. By mid-April, I think it's April 15th, McKesson, who's the main medical supplier for lots of different facilities and medical practices, thinks they'll have the supply will be shored up. But that's, 3 weeks away.
Sure.
So that's where things are. Gowns are still in short supply, and so are face shields. So things are still, unfortunately, in short supply. Then the question, I'm sorry, you asked about testing. So things are ramping up. You may have seen the FDA has put a kibosh. They reversed their position, and they put a kibosh on home testing. So they're not allowing home testing. There are a couple of companies that set up to do home testing, and they actually started shipping. And they have now denied that. Even if you had done a sample and you sent it back, they will not process it. They have to destroy them. So that's ended for better and worse. I think they're worried about quality control. And then there's UCSF and CPMC and Marin General, or I shouldn't say Marin General. It's actually the Department of Health and Marin. They have an undisclosed site, which I know where the site is, but which is behind the Civic Center. But those are the main spots. And Stanford. So Stanford's been able to do a very high throughput for a long time now. And so they're much more lenient on their criteria. I had someone denied UCSF, even though they approved it when I talked to them. Once they spoke to the patient, they weren't sort of sick enough, so they actually wouldn't do it. So those are the three places. And then there's the other screening is option, which is also sort of relevant, is antibody testing. So that'll help you know if you're immune or maybe sort of somewhat newly exposed. And that's not yet easily available, but it's coming into practice soon. These are called these RDTs, just rapidly.
Somebody has to mute. They're causing a problem.
Oh, could everyone go on mute again? Thank you. So thank you. That's much better. So these rapid diagnostic tests that are antibody tests, they're not helpful for acute identification though, but they would tell you if you've been exposed. So that's helpful too, right? Because then you don't have to be worried. So if you had IgG, which is the more mature response to a pathogen, if you're exposed to something first, IgM lights up, and then IgG comes later. Although the studies I've been reading look like they're somewhat overlapping for some reason, the studies I'm reading. But that IgG is a mature immune response, and that means that you're now immune. So it'd be great to know that too, right? Then you could actually re-engage and go back in circulation. But all those tests aren't quite out yet. These tests are available in China. And so the question is, do I get some and use them with my patients? They're not sort of FDA approved. So we're trying to sort of sort through some of that.
Yeah, but I was just thinking more from a public health point of view, because we saw in South Korea and in China, they tested the population so they could sort of predict if the curve was going to go sharp up, how many people out there were tested positive. I was just thinking in terms of, you know, having a sense of how many people in the Bay Area are walking around with this, and if you can predict what would happen in terms of the surge from that. But it's obviously not going to be the policy here in the United States. We don't have enough tests to do that.
Right. So I contacted the Department of Public Health, and I heard back today. So one of our patients has access to a large number of rapid diagnostic tests out of China, and actually there's another person I know that also does. And so the response I got back was, "Have you submitted these tests for FDA approval? Or they've been submitted? Does FDA sort of signed off on them or not? Otherwise, we can't really engage with you." So there's some hiccups in the process. They want to be able to they want it to be reliable, so that the data they're receiving is good data. So that makes sense. And at the same time, we have this epidemic. So there's sort of that tension. And there's a company in Silicon Valley that you may have seen that's been doing that's sort of FDA approved to get their tests up and running, but haven't done so yet. I will say, so Bill was kind enough to share a website under the chat, if that's of interest to you. If you know people that have masks and gloves and other supplies and they want to donate them, I know that the medical students organized this for UCSF, and they actually got 14,000 masks donated. They received, I think, a couple days ago. So yeah, any other questions?
Hey, Brad, this is Jonathan. Along the same lines around testing, so I was sick a couple weeks ago, but I also work with a number of colleagues. Half of them were sick with something, and I think the paranoia level is kind of high, as well as just a number of friends that, could have been easily a common cold. I guess from a guideline perspective, just purely from a public perspective, what's the most responsible way of going about it? Do you just hang tight until you get the flag saying, hey, it's okay, let's get tested, either for the antibodies that you had it and you're immune, or that there's enough bandwidth that if you have any sense that you have it without a fever, but maybe you have a cough and it's somewhat borderline, that you're able to get tested?
Yeah. So there's a good chance what people are getting is RSV or some other virus, common cold, right? So that clearly is what people are getting, because I've tested many people that come back negative, and they had something that I thought could very well be this, but they came back negative. So now there is a window, and we could miss the window. For example, I tested myself 17 days after I started having symptoms, because it took the Quest that long to get the right test to me. They sent the wrong batch. And the only reason I have the test, by the way, is because I ordered them early enough when no one else knew about them. And then they sent me the wrong ones because they they didn't understand how to send the right test. And then they sent us the right ones. So we ended up getting the right test, but no other doctor I know in the Bay Area has been able to get very many. I mean, a couple docs, but it's been very hard. But I was 17 days past, and it was negative. So there's a chance I had it, and I just the virus wasn't high enough in my body anymore, so it was a false negative. So in other words, if I took the antibody test, it may be positive, meaning I'm immune, that I had it, but it wasn't detected. So to answer your question, which is the opposite of that, is if you have symptoms, I would treat it as if you may have it, and I would self-isolate yourself. How long is then the next question. So historically, people have been saying 2 weeks. The data I just showed you said, is it 3 weeks? But the caveat being, if you have antibodies by day 5 or 10, maybe you're not as contagious. So definitely 2 weeks. If you want to be extra safe, 3 weeks is how long you should pretend you have coronavirus, not knowing by test. Unfortunately, that's the current situation. I'd love to be able to say, I'll send you a rapid diagnostic test. You could do it on yourself. You prick your finger, and it'll tell you if you have antibodies to it, and then you would know if you had antibodies, and then you'd be, good to go. And if you're negative, it doesn't mean necessarily that you don't have it. You just might not have mounted antibodies yet, if that makes sense. So there is a window, roughly day 10 is when the antibodies start to show up from symptom onset. So we'll cross that bridge when we can, if we can get these tests.
Thank you.
Can you hear me?
Yeah, hey again, yeah.
So you showed us data that showed a surprisingly high number of younger people, I guess it was under 40 something, that ended up hospitalized. You also mentioned that data may be preliminary, it may not be accurate. But I'm wondering if, the idea of sending that younger, lower risk population back into the workforce after some number of weeks, why wouldn't that be risky from the standpoint of if a number of those people end up getting the virus and end up needing to be hospitalized, that then in turn overwhelms the hospitals, which is what we're trying to avoid.
Yeah, sorry, I had to go in and out for a moment there. But if I heard you right, you were asking if you put everyone in circulation, it looks like a large portion of the people, a large minority that are being hospitalized are younger in that, quote, non-vulnerable population, but aren't they vulnerable because they're being hospitalized? True. And I think that's why we need to hold out a little bit more to see how it plays out. That's what that data showed. I think the data is early. And we're only admitting people that are super symptomatic. So that may bias. If you guys can go on mute again, because there's an echo, that would be great. That may bias who we're seeing. So I think we don't know enough yet to answer that question. So it would be too early now to put everyone, but if it's behaving how it was behaving in China for sure, and I haven't seen a lot of data out of South Korea that I need to look for, and Italy, then we'll see, and I think we'll get a lot of information from New York soon.
But Brad, I wanted to comment that in Chile,
Yeah.
they're seeing the same pattern of younger people being hospitalized.
Mm.
So the people are starting to think that there's kind of a mutation of some sort because the pattern is different. I mean, we don't have that much data yet because the numbers are smaller, but that's what they're seeing.
Yeah, I guess, yeah, either it's mutating or perhaps or
It could be
ethnically,
demographics.
or humoral response may be different from Asia as well. Yeah. Well, interesting. Okay, well, that's concerning if that's the case. So we'll see.
Brad,
Yes.
this is Mary jumping in. Hello.
Hey, Mary. So go ahead. Let me introduce you for a moment. So Mary is a guest expert. She's a virologist who's done a lot of work with the Department of Defense and a lot of other entities looking at emerging pathogens globally. So she's been helping me make sense out of the chaos. Hi, Mary.
Hello. And hello, everyone. It's such a pleasure to join this call. As a hemorrhagic fever virologist, I love silver linings. And one of the things I'm seeing emerge out of this pandemic is tremendous collaboration and community. So this is, it's quite astounding to me to see how this is bridging gaps and bringing people together despite some of the negativity that I know we're all feeling. But I did want to just mention one thing, and Brad, you've done a great job of pointing this out. We're in the early days with this. We really are in the early days. And we're not considering some of the variables that will be considered most certainly down the road. And I've been giving a lot of thought to this business of the statistics emerging out of the younger generation. And there are factors that we have yet to consider. For example, vaping, e-cigarettes, things that might be compromising the lungs of the younger population. We don't know what impact that is having. And I'm certain we will realize that maybe several months, maybe a year down the road, when we can really look back at the factors, at the epi statistics, the variables that are being thrown into those equations. So I did read an article today where they were talking about the fact that there seem to be, yes, there are mutations occurring, but they don't seem to be as extensive as one might expect. And that's promising from the perspective of developing a vaccine that can protect the population for the long haul. So again, these data inputs that we're receiving may change over time. And from where I sit, they're changing day to day. I agree with Brad. I get online every night and I'm amazed at what new content is out there in the literature. So anyway, I just wanted to mention that.
Thanks, Mary. That's really helpful. Yeah, I should just mention just this point of reference. So Mary, thank you for your help. Another person that's been helping who's sleeping now because it's 1 a.m. or 2 a.m. I guess, is a gentleman named Ruben Granich, who's a retired CDC, WHO, MD, epidemiologist. He's done a lot of public health work. And so he's been really helpful in helping us sort of think about this. And I would like to just echo what Mary's saying. There's been a huge amount of collaboration across hospital systems. For example, at UCSF, a couple of faculty that are friends at UCSF, they have just said it's unbelievable how the labs are sharing data within the hospital and across hospitals and through the Bay Area and nationally at a research level. It's really forced everyone's hand, and people are putting stuff on open source to look at the genome, and like the world scientist collaboration has moved to a level that that progress is being made at a logarithmic level. So that's the good news. There's a lot of good stuff that's from this. The other good news at a medical system level is telemedicine now is going to become much more sort of part and parcel of healthcare, because UCSF in 1 week moved the entire platform to a health telemedicine platform, which is amazing if you think about how large of a system that is. But any comments or responses or questions to Mary or myself?
I'm trying to wrap my head around managing the risk presented by asymptomatic people, whether that be people that I might come in contact with or myself, given not having much in the way of symptoms. My inclination has been to be pretty risk averse in terms of going outside to an absolute minimum, even trying to avoid being in stores, wiping down deliveries, those kinds of things. Is that a little overly paranoid? I mean, it seems like that the smart play is to avoid the need for medical care, and that the way to do that is to make sure that you don't get infected, and then of course by reverse that then you also don't infect other people. What's your take on what's a sane, reasonable amount of risk management there?
Yeah, so so my opinion about that, Mary's is a little different. We've had conversations about it. My opinion is most people, so we think we don't have hard data on this yet, but we think most people are getting it through contact, right? So like yesterday I was at the pharmacy picking up some medicines for a family member, and they're like, put your phone number in for the rewards or whatever, right? Hit that keypad, and you got to sign there, pick up that pen and sign, and you realize like all the things you touch that everyone else is touching, particularly at the pharmacy, right? Where people are there because they're sick. So I agree with you. I think you should be thoughtful about when you're outside. So door handles, touching things that are common stuff. So you can wear gloves, or if you're touching those things, use hand sanitizer in a thoughtful way. So whatever you're touching, you're grabbing, putting into your cart or whatever you're doing, and then putting it into your car, let's say, and then you're using hand sanitizer if you're not using gloves when you're done touching it, right? And then you get into the car and drive your vehicle. I would then also use wipes, wipe down your vehicle, because you may forget. And in the places that you touch. And so that's then shipments, if you're receiving stuff that's coming in through mail. Again, we think it lives in 24 hours on cardboard. So we might want to then think about, okay, you can create sort of a station where you put stuff and let it sit for a couple days before you bring it into the house. So that's the other option, is sort of, or you could wipe it down with a wipe before you open it, or you open it and take the stuff you want out and then just go wash your hands. So remember, soap and water is great. Don't have to always use hand sanitizer. And I would say if you can use soap and water, my suggestion is you do that over hand sanitizer. But if you can't and you're out and about, hand sanitizer is great because it's super convenient. So if you could create an area where you put stuff, almost like the mud room, and let it sit until that viruses can then die. That's one way. Or what I did at Box Cam is I opened it all up, and then I sort of, when I was done, washed my hands thoroughly. So there are people that are wearing masks. I'm less of a fan of the mask. I mean, that requires someone has to cough basically in your face for respiratory droplets to land on you. Now, if they're in, Mary and I had this conversation around, you're shopping in an aisle, and someone sneezes or coughs 2 aisles down, you don't hear it. You then go into that aisle and grab stuff. Now, and their droplets landed all over the stuff that you're touching now, right? That's why you want to wash your hands or use gloves. Can it be aerosolized? Is it sitting in the air and you walk by and breathe it in? We don't think so. Now, then again, there is a concern if you, for example, some of the docs I work that are my colleagues that are in GI doc, for example, if he's doing procedures and people are coughing out, then there is a concern for aerosolization. But generally speaking, I would say, in my view, that you don't need to worry about and therefore don't use a respirator. I think Mary has a different opinion. You want to comment, Mary?
No, actually, Brett, because I've given this a lot of thought. A lot of folks have asked me this very question, and I've always been a proponent of the individual who is infected, is sick. They are the ones that should be wearing the mask. Those who aren't shouldn't be wearing masks. And unless they are really in an immune compromised position and they're going out into a general public setting where they're going to be within a distance that's not of the recommended length. And the reason for that is these N95 respirators, as we call them, they have to be properly fitted on the face. And so you risk getting contaminants within the mask if it's not properly fitted. So you could be a healthy individual, come in contact with somebody who isn't. If they sneeze within your vicinity, there's some small chance, we don't know what the chance is, but you could get that in your mask. And then you're just re-inoculating yourself all afternoon because you have this mask on your face or for however long you're in that position. The other reason is, and I've seen this numerous times in public, I've watched many people get on planes with masks and then they fiddle with the mask with their hands that are now touching everything else on the plane. So people don't know exactly how to use the mask properly, and it gives them a false sense of comfort. So where they might be more concerned with touching their face, they're less concerned and they're touching their face just as much as they would normally. So masks are good, again, for those individuals who are either ill and have to go out into the general public, or for those individuals who are immune compromised and are in the general public. That's my opinion about masks. As far as what Brad, you had mentioned, I'm on board with all of that. I myself, if anyone is interested in what I do when I go to the market these days, which I don't do hardly at all anymore, either curbside pickup or delivery at your door is a great option. But I have taken my alcohol wipes and laid them on the handle of the cart, so I'm always in touch with that. That gives me a sense of security. I think in terms of what makes sense and what doesn't make sense, Brad, you've given a great overview of what does work. I think there's ranges. You can do what Brad said. You can just get your stuff and wash your hands. Your friends your biggest friends are your elbow and your and soap and water. Hold on one second. Somebody is talking in the background. Can you tell her to just, I'm at home right now and I have an 87-year-old mother who doesn't hear quite well. Brad knows her quite well. But anyway, so elbow, soap and water, those are your friends. But the last thing I wanted to mention is if you want to go the distance of isolating your goods when you bring them into your home, that's fine, because whatever is going to give you peace of mind is going to reduce your stress level. And that's an important part of prevention, is to just make sure that you're as calm as you possibly can be. We're all worried about our loved ones. Taking that time to say, what is going to make me feel most comfortable for those around me and for myself is highly important. If you're a little over the top, like I am, because I worked in biocontainment for years, I'd go the extra mile just because that gives me peace of mind. Is it necessary? I think soap and water is great. It's fine. Whatever's going to give you that level of calm is perfect. Social distancing, for sure. That's going to protect you. All the data are indicating that. And it's really not that hard to do. Today, it's not that hard to do. So that's my input.
Thank you. Yeah, and then on that note, I said we'd be an hour and 20. So let me just, the final thing I just want to bring up, which just to feed off what Mary just said, is our immune systems, really function best when we are rested and when we are managing our stress and taking care of ourselves, when we're eating well, when we're exercising. So some people, being at home can do a couple things. It can make people, I can tell you in my home, we've got 2 teenagers and they are not happy to be in the house. My one 14-year-old daughter said, she said, "Oh my God, and now I have to spend 24 hours a day, 7 days a week with you? This is going to drive me absolutely insane." And, she's like, we're 7 days in, this was a week ago. And she's like, I'm going insane, but it's real important that we take care of ourselves as best we can. We're fortunate, we live in the Bay Area. We can go for a bike ride. We can go for a hike, go for a walk. Please do that every day. Don't all show up at the beach at the same time. I'm sure you saw stories about that, but there's plenty of space to really go and have some time. So please do that, and please work on sleep as well, trying to find a way. And most of it, honestly, the core of it is our minds and our sort of our emotional reactivity. So that's why I wanted to start with this meditation when we started our talk, our conversation here today, is just to be able to ground ourselves. And if that or yoga or whatever works for you, I would encourage you to do it every day, just a little bit every day. So if this has been helpful, I think at the end of this, I tried to set up so you get a little feedback. You can answer 2 questions. Was this helpful? What more would you like? I'm happy to do this every week and until it becomes less relevant or meaningful for us. So I thought we'd schedule it again for next week as well. There was a question about, okay, is delivery of food safe? I want to support local businesses, but worry about folks preparing if they may be carrying it but asymptomatic. So it's a good question. So what is it like, if having groceries delivered to you, if you can, nowadays it's so difficult because they're all booked, or takeout, that's delivered, food from restaurants delivered to support local businesses, which I highly encourage supporting local businesses because they're going to have a rough go and still are right now. So I would take the container, if it comes in containers, this may sound like overkill, but I would wipe them down. I would take wipes, wipe it down. And then you could do what you want with it, and then wipe it all down and then wash your hands and then, get out the utensils. And I would just be mindful about it. Or if it's raw goods, groceries, similar thing, we already sort of talked about that. So when I said a cardboard box, the same story, canned goods that are being delivered to you, and if it's fresh produce, then you could wash it with soap in a sink. as well as a basin. So I would just sort of treat it all as if you're living, if you're living overseas in places that don't have clean water, you sort of have the same mindset, and we need to switch into that mindset. Okay, I want to respect everyone's time. Thank you, everyone, for showing up as well. Love your feedback, and I wish you all well. Have a good night.